Okay, this is it. Last one. All right, so we're still talking about rheumatoid arthritis. We're going to talk about some of the drugs. The first drug I want to talk about is methotrexate. This is the second-line medication used in children who have failed NSAID therapy alone. We can use methotrexate in combination with NSAIDs. We need to discuss with teens an alternative form of birth control, or I guess I should say a form of birth control, because if they were to get pregnant on methotrexate, there would be birth defects involved. Methotrexate, we also want to monitor our liver function. So we're looking at our AST and our ALT, and then we want to monitor the complete blood count. The next slide talks about our slow-acting antirheumatic drugs. Again, they're slow-acting, so it could be months to be effective. And guess what drug falls into here? You guys hear about it every single day on the news. Hydroxychloroquine is a slow-acting antirheumatic drug. It does have effects on the immune system, so again, we're checking our CBC. It does not have any anti-inflammatory properties, so we can either give this alone or we can give it with NSAIDs for inflammation. Some side effects of slow-acting antirheumatic drugs are oral ulcers, protein in our urine, WBC and platelet count alterations are seen. That's why I said they need to monitor the CBC. Visual complications, alopecia, anorexia, abdominal discomfort, and neuromuscular weakness are just a few of the things that we look at. All right, let's see, what's my next drug? My next drug that I want to talk about is corticosteroids. Don't forget with steroids in kids, or steroids in everybody really, we administer them at the lowest effective dose for the briefest period, and then when we stop them, they need to be tapered off. We try not to give corticosteroids because it usually does interfere with growth and development. We typically give steroids in kids for life-threatening complications. In this case, it would be severe arthritis. Steroids can be given orally, they can be given right into the joint itself, IV push. What we need to teach if they're on steroids, weight gain, especially in the face. We talk about that moon face and buffalo hump. Again, those would be long-term steroid use. But again, weight gain, you're always gonna feel hungry. Make sure we're have some healthy eating practices set up. We do want to monitor their height and weight because we said it does alter their growth and development. And again, they will gain weight, but they're not going to grow in height. And then we know with long-term steroid use, it decreases our immune system, so we need to monitor for infection. All right. And there are other side effects of steroids, you know, elevated blood glucose, so hyperglycemia. Make sure you're bringing in all your other knowledge on steroids into that. All right, our next medication is tumor necrosis factor. It's an inhibitor for the alpha receptor blocker. Enbrel is the drug that I'm talking about here. You probably see this on commercials a lot. So we use this type of medication for children who are non-responsive to methotrexate. We typically give it 2 times per week subcutaneously. Side effects are allergic reaction at injection site, increased infection risk, so it decreases the immune system, and pancytopenia. And if you remember from our oncology lecture, pancytopenia is when everything is decreased. WBCs are decreased, platelets are decreased, RBCs are decreased, so we see all of that. All right, in addition to medications, we make sure we're doing physical therapy for kids with RA. We want to increase or maintain strength and range of motion. We want to promote independence in ADLs and ambulation. We need to control pain before and after physical therapy. We need to make sure that they are balancing their exercise, their activity with rest. Fatigue is a prominent problem with this diagnosis. And again, we want to teach them some rest and relaxation techniques as well. More physical therapy. I think there's 2 slides for physical therapy, or several slides for physical therapy. I don't know why my thing won't slide down. All right. Physical therapy, exercise all joints through range of motion, active range of motion, as long as they're not having a flare-up, twice a day. Swimming and bicycle riding are good exercises for these kids. Normal play and school activities are not enough. They need more to keep those joints functioning. Remember, we said if the joints are actively inflamed, we do passive range of motion, simple isometric exercises, or we may even just rest the joints. It just depends. We talked about early morning stiffness is what these kids typically complain of. Remember, we're waking them up an hour before they actually get up, giving them their medications when we wake them up, getting them into the hot shower, hot bath, whatever helps. Heat and warmth will keep those joints comfortable. Again, we could use splints to protect from deformity to rest joints. Contractures could be a side effect for kids with RA. Surgery could be an option to help release those contractures. And then again, another surgical option would be joint replacement, only in older children after bone growth has ceased, though. The next slide I'm looking at is your home maintenance slide. Home maintenance for these kids, again, teaching family as well as the patient, administration and side effects of the medication. Good nutrition, PT and OT, ways we're going to decrease pain, ways to decrease fatigue. Make sure they're giving the children chores around the house so they can perform those and feel like they're an active part of the family. Again, I said they will go to school regularly. Their school day could be shorter depending on the amount of fatigue and pain they experience. Everything will be kind of individualized. It never fails. Every semester I have a student who knows of somebody with RA and they're like the most active kid ever. I've had football players, hockey players, soccer players with RA. It's kind of no big deal for them. They're just going about their business and all the interventions are working, so that's good news. Don't forget, there are support groups for these kids as well as camps specific to kids with RA. All right, the last part of our lecture is bone tumors. The first one we're going to talk about is osteogenic sarcoma or osteosarcoma. This is on page 1319 in your text, so it's back in the cancer chapter. The reason I'm talking about this is that it's the most frequent malignant bone cancer in children. We typically see a diagnosis between 10 to 25 years of age, and it's typically adolescent males. Incidence is higher in the most rapidly growing bones in adolescence. Those will be the distal femur, the proximal tibia, and the proximal humerus as well. Trying to make sure okay, good. I shouldn't be skipping around here. Let's see, signs and symptoms, pain, non-specific pain. It's often mistaken for growing pains. Kids complain that their bones hurt. Oh, you're growing. We could see swelling. Pulmonary metastasis is present in 10 to 20% of these kids once they're diagnosed. We could see weakness, decreased movement of the extremity. If there's any lymph nodes near the tumor, we can palpate those. Anemia, generalized infection, unexplained weight loss. With osteosarcoma, cause is unknown. They do suspect there is a genetic link. We diagnose osteosarcoma using an X-ray, a CT scan, a bone scan. Once we see something on one of those scans, they can do a biopsy of the tumor. We can also, a blood test, you look at their serum alkaline phosphatase. Your serum ALK phos could be higher in bone cancers. So that's something as well. All right. See, I think our next slide should be our treatment slide. Our treatment is surgery. Chemo before and after OR could end up in amputation. There could, one of the surgeries, it could be a limb sparing procedure or a limb salvage. They go in and they resect the primary tumor with prosthetic replacement of the involved bone. So that could be an option as well for these kids. Your nursing care would just be honest preparation. Don't forget our age group is typically a little bit older. You would explain lack of alternatives. Obviously, losing a limb when you're a teenager would be a huge blow, definitely lifestyle change, dealing with lots of feelings there, anger, fear, aggression. With amputation, remember we talked about our stump care, the figure 8 bandage. And why we're doing that, we want to form the stump, keep down swelling, mold the stump, getting ready for the prosthesis. It also helps with hemorrhage after surgery. We're worried about hypovolemia. They'll go to physical therapy. We will, once the prosthetic comes into place, we will make sure they're educated on how to care and how to use the prosthetic. Remember I talked about phantom limb pain. So they have their limb amputated and they swear that they still feel it. There's pain in that limb. A lot of times we'll use a mirror so they can see that the limb is no longer there. We also use Elavil, and if you remember from mental health, Elavil is a tricyclic antidepressant, but it works great for phantom limb pain. So we'll use that here as well. Discharge planning. Here is our next slide, and again, depending on what stage they're in, you could role play about using the prosthesis. They're probably going to go home wheelchair or crutches. Again, we talked about those environmental barriers. If they're going home on crutches, PT, OT working with them, wheelchair as well to get in and out of the wheelchair. Not only are they dealing with this surgery and loss of a limb possibly, but this is also a life-threatening illness. So we need to make sure we're supporting that piece of it as well and bringing in all of your chemotherapy knowledge into this conversation as well. Dealing with alteration in body image and functioning, grieving process due to loss of limb, and then we also have to deal with the parents and their grief and their guilt because they're the ones ultimately who are giving consent for this amputation. On the upside, when we talk about these prostheses, I do think there's a ton of great role models out there that kids can look up to, tons of things on YouTube, tons of athletes doing all sorts of phenomenal things. We see it with our soldiers if they lose a limb in combat. And also even for little kids, I think of the American Dolls and the other dolls that do have prosthesis now, or they're using a wheelchair or a walker. So that's one of the benefits of social media, in my opinion, for this. All right, the last bone cancer we're going to talk about is Ewing's sarcoma. And if you flip the page, if you're on 1319, Ewing's sarcoma is on page 1320. This is a malignant small cell tumor in the diaphyseal portion of a long bone. We typically see these in the femur, vertebrae, ribs, and or pelvic bones. The diagnosis for these kids is between 5 and 25 years of age, so kind of a bigger spectrum here. Signs and symptoms would include fever, increased WBC, increased SED rate. Diagnose it, again, same way we're looking at those different scans. We see a tumor on those scans. We need to biopsy that tumor to get a definitive diagnosis. Prognosis will depend on how quickly the disease was diagnosed and whether or not there was any metastasis. So we would take a look at that. Treatment for Ewing's sarcoma is radiation and chemo is the treatment of choice. If that's not working, surgical removal of the entire bone, that's not typically routine. Again, make sure you're bringing in your chemo and radiation knowledge to this content as well. With radiation, you want to protect the unradiated area, the area that's been radiated, where you want to watch the skin, protect from sunlight. Don't forget they have intolerances to heat and cold, so we might not be using heating pads, we might not be using ice packs in this patient population. Again, just make sure you're looking over your radiation notes. And then chemo as well, the signs and symptoms, you know, our hair loss, our nausea and vomiting, our peripheral neuropathy, what it does to our blood cell counts. We're at risk for infection. So just make sure you're going over your chemo notes as well. All right, that's it. Last one. Although I will be lecturing on those other case studies at some point during the week. I'll get those out to you.